For those of you who do not know me, I am Cindy Ehnes, and I'm an attorney, and I have been in the practice of regulatory law for approximately 20 years now. Yikes. And essentially have focused that on insurance and insurance products with an emphasis on healthcare. And that is my passion, and I know I share that with many people. And so today we are going to be talking about the Affordable Care Act, and this is only intended for your benefit. So if in fact there are things that we're not getting to, that are questions you have, then feel free to ask questions. And if I feel like, okay, we're going to answer that later on, I'll just say, hey, we'll do that later on. But don't be afraid to ask questions. So it's going to be 5 years ago, right now, that the Patient Protection Affordable Care Act was signed into law. And what we're going to be talking about is the impacts on healthcare delivery that it has had in this 5 years. And so the impact, we're going to focus primarily on California, because in many ways California is a leading edge state on many of these implementation issues. And so we're going to really focus on that because, again, too, you're in school in California or in work in situations in California. So what I wanted to do was, first of all, talk about why is the Affordable Care Act constructed the way it is? Why was that necessary to have the particular solutions that the Affordable Care Act has? And then talk about the fact that many of the aspects of the ACA are in fact from conservative proposals, and I'll talk about that. And then we'll talk, of course, about the issues related to the conservative attacks on its Supreme Court decision, and then what's going to happen over the long term. And then also talk about the aspects of the ACA that I think are very good, and then also some that I think are bad, and then go into things that I think are extremely important for those of you really starting in your careers to understand. Because the one thing you must understand, that just as if you had come into your careers in 1965 when Medicare passed, and you sat there and you said, wow, I wonder if this is going to have much impact on me. You are in a very, very pivotal role, defining period, and your careers will in fact be defined by both perhaps some of the legal aspects, but primarily helping people, helping the organizations, institutions to figure out how do they navigate all of the impacts of the Affordable Care Act. So again, the good old days were very much about pre-existing conditions. I'm sorry, Mr. Dumpty, but gravity is a pre-existing condition. That was the life that we knew. And so I want to talk to you about how I got into health law. And folks who are with COPE actually have heard the story probably ad nauseum. But I think it is actually really important, not just because I'm saying it, but because it is in fact the defining experience of so many people, so many Americans. And that is that I was an attorney practicing business law primarily when my second daughter was born, and my second daughter was born with a very serious case of asthma. It is a pre-existing condition. I mean, she just almost died a few times, in fact, a lot of times in her first number of years. And at the time in Colorado, because she had a pre-existing condition from birth, our insurance company, our health insurance company, would not accept her on our policy. And so we found out, you know, again, I was an attorney and never, of course, read my policy, knew nothing about any of the laws that related to health insurance, mainly because I thought, well, gee, I'm relatively healthy and we've never had a problem. And all of a sudden, I find out that my baby daughter cannot be covered under our policy because of something that she has no power to change. It is her birthright. And I turned into a different person. I turned to a different career overnight. Just like that, overnight, I became Mad Mom and a warrior for social justice in this realm. And because it was such a pivotal thing in our life that was going to define her existence, her access to health care, her access to routine preventive care, her access to medications, were not issues for somebody else. They were on my plate as a mother to solve. And believe me, I got out there. And so I became, you know, again, an advocate for solving this issue, and went into my career and became helped to start an uninsurable plan for people who are medically uninsurable, which is the conventional old solution. Is you start a high-risk pool for people who can't get coverage. You charge them a lot of money, and you keep them separate from the good people who are less expensive. And I helped to start one of those plans in Colorado, helped to run it, was chair of that, and then was invited by the governor to come to the Department of Insurance in Colorado to help to actually be their director of enforcement. Then I came to California, was appointed by Governor Schwarzenegger to be the director of the Department of Managed Health Care for the state for 7 years. And in that position, had the opportunity to work with the governor and with the other health leaders in the state to fashion the governor's proposal in 2007 to do what the ACA did in 2010. And that was to fashion a proposal to give access to everyone for health insurance, and it was going to be at a state level. Ultimately, we were not able to get that program through. We were done in by Sheila Kuehl, and who wanted a single payer system more than she wanted anything else, and so, you know, for that reason we weren't able to get it. But we had to really figure out, how do you solve this problem? How do you start from a what you call in law sui generis, meaning start right from the beginning and just think through. All right, first thing is, well, first of all, let me ask this. How many of you might be considered medically uninsurable? Meaning you have some condition that you're being treated for. Asthma? Allergies? Any?
Allergy.
Okay. So under the old regime, you are not insurable, likely. And how many of you have a family member who has some kind of condition that would make them uninsurable? So again, we are solving, if we're thinking about how we're going to solve this problem, we have to solve it for all of us, because we all have a stake in it, whether it's direct or indirect. So the first thing, the first way to solve that problem of how do you make sure that everybody has access to health insurance is to basically just tax everyone and essentially just tax everyone and create a single payer system like Medicare. That would be the most direct way to do that. But of course we know that that is politically untenable. And I'm sorry, I got ahead of myself. So we know that's politically untenable, so how do you start solving it a different way? First of all, the first fundamental thing you have to do is make sure everybody has the ability to not be denied, to access it and not be denied based on a pre-existing condition. So in order to do that, you have to make sure that people don't just buy coverage when they're healthy. You have to make sure that they buy it before they need it. That's exactly the way any insurance, any private market insurance coverage for your house, for your car, for any of your other insurances is basically that you cannot purchase it before you, you cannot purchase it after you need it. So with a car crash, of course, that makes sense. You know that, wow, I wasn't covered at the time of my crash, and therefore I don't have coverage. In healthcare, of course, that's not the case because you have an emergency visit, and then you go out and you could buy your coverage potentially and be covered for all of that without ever having paid into the system. And insurance relies on the fact that 90% of the people are paying in and not needing the service, and 10% are accessing it at any time. It's a rough metric, and it doesn't apply as well in healthcare as it does in other insurance products, but that's essentially the grounding, is the 90-10 rough rule, that 90% paying in, 10% using at any time. Well, again, if you guarantee issue but don't require people to purchase it, then in fact you can't achieve any kind of ratio like that. So you have to figure out, how do we get people to purchase it? Well, you then say, all right, you're mandated to purchase it. But if somebody can't afford insurance, then what are you doing? Then you can say, well, you have to purchase it, but yeah, I can't afford it. So then that's where the subsidies end up coming in. You're subsidizing the purchase of that, the premium cost, but at the same time, if you end up with maybe you end up with a policy, but you're very poor and you can't afford the co-pays, then what do you do? So then you get into the subsidization, not just of premium costs, but of all of the subsidies in the cost-sharing realm. Well then, how are you going to afford the subsidies? Premiums generally will support the structure of the healthcare costs. That's the actuarial requirement for a health plan, is to make sure that its premium costs overall are covering the costs of coverage for everyone. But when you get into those subsidies, or excuse me, when you get into subsidizing all that cost sharing, you need an independent source of revenue. So that independent source of revenue is coming from the federal government, and that is subsidizing those co-pays, and it's doing so in the form of tax credits primarily, but the cost-sharing subsidies come directly to the providers. So you're trying to figure out, okay, how do we make sure that the individual gets the support for the premiums, but we can't send the cost-sharing dollars directly to the patient, because guess what? They won't use them to actually pay the providers. So those we send directly to providers. Well, now you say, okay, we've provided these subsidies. How do we pay for them? How are we going to pay for those subsidies? Then you get into the provisions of the ACA that talk about the fact that there are certain aspects of healthcare that we want to disincent. So you'll see in the Affordable Care Act, you see that there are provisions that say gold-plated medical devices are going to be taxed. So if a certain hip is satisfactory, then if you get the gold one, then you are charged more for that. You pay a penalty in the form of a tax on that. Another aspect is I'm sorry, I lost it. I forgot. So, but you're, again, just trying to disincent certain things that contribute to healthcare spending without adding value. Yes, Josh?
Is this one of those concerns that comes up in physician circles of prescripting the way we do medicine, limiting the types of devices, medication they might have access to prescribe? Is this where that all comes down? It's that gold version versus the standard version?
It's part of that, yeah. Yeah, there's, I mean, that's definitely one of the aspects, although, you know, that tends to be a bit of a, that's an industry issue. The medical device industry is fomenting a lot of that. That's the first rule of healthcare is no one wants their ox gored. And so when your ox is getting gored, you create a constituency to go fight that issue. I know what I was forgetting is the gold-plated union benefits. I mean, you've heard about that the Cadillac tax on what are considered to be a high level of benefits, so that you're going to be taxed on that extra benefit level. That predominantly affects unions. So that's really it's the Cadillac tax, but it does primarily affect unions. So, all right, now you've figured out that structure. The one thing you haven't done is create any pressure to keep costs low so that people actually can afford coverage and the subsidies aren't stealing a lot of money from the Treasury. And that's where the accountable care organizations, all of the aspects of the ACA come into play that are talking about system reform. And the big one there is accountable care organizations, the Medicare shared savings programs, the Medicare Advantage plans, all of those kinds of things are looking at how do we in fact transform the delivery of care to make the cost lower and the quality better. So what I'm saying is that when we in Governor Schwarzenegger's office sat down and said, how would we design that? We essentially came up with Obamacare, much the same way as Massachusetts essentially came up with Obamacare, because by solving each of those elements required to support and enforce the right to purchase coverage at any time, essentially, that you can in fact access it without a pre-existing condition or a pre-existing condition period. It requires all of those supports, the buttressing that the additional elements of the Affordable Care Act create. So that's why, I mean, I'm telling you that because I want to make sure you understand the interdependence. So when you start hearing about ideas about, well, we'll just take this one out and we'll just take this one out, we'll talk more about that. But where you end up with is a situation that, again, you'll be able to analyze that now because you will be able to say, look, if I want a guarantee issue coverage, then what are the supports that are needed to do that? So that's why I spend a little time on that. But I'm always surprised. Oh, what did I do? I'm frozen, Alice, which doesn't surprise me. Maybe I turned it off? No, I turned it on. The clicker is, what happened?
Is it on?
All right, got it. Thank you for you. So the one thing I always ask is why aren't conservatives more happy? I mean, this is their version of health reform because many people, including me, are single payer advocates. And we are for many reasons, some of them philosophical, some of them just complexity. I mean, to me, Medicare works and Medicare for all makes a lot of sense to me personally. But, again, why aren't they happy? It's not a single payer system like Medicare. It requires individual responsibility. It's a market-based approach. It's saying, and a state-based approach. It was states, you go out and create your exchanges. exchanges being a competitive marketplace where we're going to select plans based on the fact of affordability and quality. And so, again, allowing also competition and individuals to decide what they want. And then the whole element of exchanges is moving, and this is a very major dynamic, moving increasingly the employer-sponsored coverage, which traditionally has been defined benefit, meaning that an employer would say, look, Josh, I'm going to give you insurance for the whole year, and you have to pay, you pay $100 a month as your contribution to it, but I'll make sure, even if the prices go up, that you in fact get that coverage. Defined contribution, defined benefit, meaning I am giving you a certain benefit that has been predefined. Defined contribution says, I'm giving you a fixed dollar amount, and whatever your insurance product costs, that's how much you get. So if I'm going to give you $500 a month, let's say, and you buy a policy that that premium is $500 a month, great. If you buy something that costs more than that, then that's on you. So that's defined contribution. Very, very significant trend. It's a trend, of course, that we've seen and that you folks are all affected by in the pension system. You are all in 401ks, I'm imagining. And so that you are not guaranteed a certain standard of product. You are guaranteed whatever money you put in, plus the employer match, plus the increase from your investments. So that's a huge, huge shift that is very, very fundamental and has greatly accelerated under the Affordable Care Act. Huge trend. And the move to private exchanges and that acceleration is an undercurrent that I keep raising my hand and saying, whoa, folks, I mean, we're just kind of accepting that that's okay, is to move completely away from guaranteeing that our poor, our lesser paid people are guaranteed a certain benefit, and basically say, hey, if you're the highest paid employee versus you're the lowest paid you both get the exact same contribution to shop for health insurance. Go with God. Major, major trend. Very conservative trend. Taxes are going to limit union benefits. The unions gave this one away. I have no idea why they did. I remember reading this and going, really? Guys, you're going to wake up in a couple of years, which they have, and realize that for whatever reason, this Cadillac tax primarily affects union benefits, and they are screaming bloody murder now. And then, again, promotes employer self-funding under the less restrictive ERISA law. ERISA law is far more permissive generally than the state regulations. So, as our first year played out last year, the good news was that people had coverage. More people had health security. That really has been a trend, and you've been seeing all of that good news. There are large reductions in the uninsured. Healthcare costs are, the health cost trends are down, but don't get sanguine about what that means. It may either mean just the lingering impacts of the recession. It may be that there are some, in fact, trends in place that are because of delivery system changes, and it may just be an impact of the industry recognizing they can't inflate prices as much. And I would ask you to keep your mind open as to what that is, because again, it's really important for you to watch that trend, because that impact of trend ends up dictating a lot of what happens in the delivery system. So, if it's just an effect of the recession, it should wear off. If it's an effect of benefits, people having to pay more, that may be continuing. if it's an effect of the delivery system getting more conscious about their ability to inflate charges, good longer-term trend, hopefully. So just keep an eye out for what that means. So the bad news is that consumers are getting increasingly grumpy and confused. And they are making very bad choices for the most part in picking bronze coverage. Bronze coverage, let me quickly go through, I didn't put, but the exchange levels have platinum, which is which will pay 90% of the expected medical costs in any year. Not your medical costs, but the actuarial equivalent value of paying 90% of those costs. The gold plan pays 80%, the silver plan 70%, and the bronze plan 60%. And we'll look at a policy and what that means. But that bronze coverage, just to put some in perspective, when I was regulating all of the products that would go out, I never would have approved a bronze or silver plan for the state of California in the 7 years I was director. And it wasn't that the health plans weren't presenting those kinds of products, it's just that I always regarded those as unacceptable coverage. Yes.
Are those the catastrophic coverage plans, or is that
They,
different?
no, catastrophic coverage is below bronze. And you heard Dylan Roby talking yesterday about a product that might just be a 50% value product.
Okay.
I mean, frankly, it's sort of like, how is this insurance?
Right.
You know, and that's really important. I mean, people have just sort of accepted these levels, but I think that increasingly as people are using this coverage, they are going to just be extremely disappointed, and that is one of my big concerns. No one's happy about paying extra taxes. My husband and I are he is really not happy about paying extra taxes. And the union members, like I said, just figured out what Cadillac tax means. It means union tax. And then the premiums are still ridiculously unaffordable given what the term buy down refers to benefit buy down. Again, an important term for you to understand. Benefit buy down means that if you are looking at an insurance product and the cost was $200 a month last year and it's the same cost this year, but in fact they added a whole lot of cost sharing and a whole lot and a higher deductible and a lot more cost sharing, and maybe drop some benefits, which they can't do under the Affordable Care Act. But that is what's called benefit buy down, meaning that the price may be the same, but they've like disintegrated the product underneath. You know, it's really eroded the value of that policy, but the price has stayed the same. So that's the term benefit buy down. So deductibles and cost sharing is very high, networks tight, and a lot of the doctors are not in the networks. So that has, of course, created a lot of division about the ACA, and a lot of that, of course, was in place from an ideological, political perspective. So 31% are saying the law should be repealed entirely, and these numbers haven't changed dramatically, so they're a little dated, but you know, 12% say they'd like Congress to scale back or in some way altered. Those are some of the numbers. But when you get down to what people really want, at the end of the day, I'll get to this slide, but really when they talk about what they want, if you take the pieces of Obamacare, if you don't use the term Obamacare, and you take the various elements of Obamacare apart, they tend to like the elements of it. Of course, they don't like any extra costs. So that's a conundrum. So just getting to the healthcare market and what's changed in the last year in California, consumers are really pretty still bewildered. They don't really know quite what's happened. They know that they had access to an exchange and that they were able to purchase a product. If they haven't used the product, they don't really understand what they bought, because no one can understand an insurance product. Because again, there's an inherent mystery to purchasing health insurance that's extremely different from purchasing any other kind of insurance. If you purchase car insurance, you have a general idea of what could happen. You understand property damage, and you understand that you could be injured. But when you purchase health insurance, you don't have any idea which benefits you might need or when you need them. And so there's no, you're always shopping in the dark. And that's what makes health insurance so difficult to really know what you should purchase. So physicians are still uncertain if they're in and out of the networks, and there are some real changes in their practice. Hospitals are very much still trying to weigh what the impacts of the Affordable Care Act are and how to become value-based in terms of their operations, lean, accountable. And health plans are still figuring out the cost and price constraints, and very significantly, how to stay at the top of the healthcare dollar. And then the brokers and the private funders, the employers are trying to develop these private exchanges, which are a growing influence. So you've got Covered California as the public exchange, then you've got all these private exchanges, like Anthem has one foot in Covered California and has created their own exchange, for example, to offer outside of Covered California. Yes?
Cindy, to go back to the narrow networks issue, so California has the lowest reimbursement rates in the country for Medicaid, and with this influx of patients entering Medi-Cal, and combined with the continued narrow networks, how do you see that playing out in the future?
Well,
and Medicaid rates, just got cut, so.
Right.
yeah. Well, they didn't get cut. They
went back to their regular.
yeah.
practice.
The primary care physician bump didn't get extended by Governor what's his name? Governor Brown. Sorry, I had Governor Schwarzenegger on the brain because he was in a movie. Have you seen him? He's in another movie, and he actually says, "I'll be back." You've got to see this. You're like, really, dude? Come on. But Tammy, I think I'm going to get to that in a little bit down the road on this.
Okay.
So I want to just quickly run through this, but one of the provisions of the ACA, the medical loss ratio provisions, is again another significant provision, and that is that the health insurers are required to spend at least 80% on their individual and small group policyholders' premiums, and for large groups, 85%. And if they don't spend that much, they're required to pay rebates. And those rebate checks have just started, well, they started coming last year, and in 2014, there was $1.6 billion in rebate checks. So I can tell you that the insurance companies do not like writing checks back to their policyholders. So that is going to drive some dynamics. And I'm not entirely, I know a couple of what their strategies are, but one of their strategies is to take, this 80% is for administrative expenses, right? But if they can reclassify some of the services that they provide that were formerly considered administrative and can reclassify them as medical expenses, then they get to keep more of the dollar. So one of the things you'll see increasingly at a health plan is a care coordinator. Instead of being a utilization manager, that title changes to a care coordinator. It's again one of the things that just you're looking at an industry, and this industry is exceptionally dynamic and wily and treacherous. I'm not a health plan fan. I mean, these guys know how to stay at the top of the food chain. So, but that's one of the, what's interesting is that that's one of the dynamics that drives their interest in helping hospitals become accountable care organizations, is that allows them to move into a slightly different posture other than just being a payer in an administrative role. So just, it's just something to be aware of. But the other thing that they are doing is their pricing, their trend lines have in fact decreased. And again, that can be just trying to stay ahead of the curve, or can actually reflect lower, the fact that they don't want to write more checks, so that their trend lines are coming down closer to the premiums. Because they have been able, in the years that I was director, able to price significantly above their trend. So, again, trend being what are their actual costs, their premium prices being whatever trend plus whatever they feel like they can charge over and above the administrative expense. So I'm not going to spend too much time on that. So the ACA has a number of provisions taking effect. The employer mandate takes effect for 50-plus full-time workers who are working more at or more than 30 hours a week to provide the affordable coverage, which is considered to be about 9.5% of that person's wages. This is when the individual mandate and fines are supposed to start, as well as subsidy corrections, meaning that the first year the federal government just said, look, you're not going to maybe be able to verify that you're eligible for a subsidy if you essentially certify with some proof, then we'll go ahead and give you the subsidy, but we're going to correct it the next year. And if you weren't eligible for the subsidies, you have to pay it back. And then CHIP, again, this isn't part of the Affordable Care Act, but is a huge deal, of course, is the CHIP reauthorization, and that is very, very dicey politically. And then the primary care physician bump, and then the issues related to providers demonstrating meaningful use for the use of electronic health records. So a tax on the Affordable Care Act, everybody knows about the King versus Burwell case. I'll spend a little time on that. We're going to continue to see that the conservative leaders are seeking to repeal or to defund and unravel the law, and those are going to continue. Budget proposals are going to continue to take parts of the Affordable Care Act and just defund them, again trying to destabilize the law by reducing its funding. But the difficulty, of course, that they have with that, the conservatives will have with that, is that it has to be budget neutral. So, for example, if you are proposing and you pass a bill that says we are going to defund the the medical device tax, you have to find an alternative source of revenue for that. So that's, again, going to hang up things. And then they've also been trying to redefine full-time work from 40 hours, up to 40 hours from the 30 hours. So it'll pull, so that less part-time workers would qualify. So the King versus Burwell decision obviously is opposed, got a lot of opposition. And I wanted to talk about what's at stake there. So the issue, and again, I think many of you know this issue, so I'm not going to spend too much time on it, but essentially a provision of the ACA, not in the main body of the Affordable Care Act, the 9,000 pages of the Affordable Care Act, but in the tax code, The tax code basically says that essentially that there are 4 little words in the tax code that say as established by the state. Exchanges as established by the states will be eligible for subsidies. So question is whether citizens living in non-state-based exchange states who are participating, who states or who are eligible to get coverage through the federally facilitated exchange are going to be permitted to receive federal subsidies, or will that only be limited to individuals who are in states that have actively elected to establish exchanges? And so a state like Oregon, for example, that originally set up to have an exchange, the exchange went defunct and they just eliminated that, would they now not be able to get these subsidies? So again, question there is, you can read some of this, but the big issue is the destabilization effect, so that you have people in California able to receive subsidies, people in Nevada not able to receive subsidies. Therefore, people in Nevada who are sick, who need coverage, will trend over to come to California. That's one of the concerns, and they would flood our market, and they would be purchasing it and destabilize our insurance coverage in a state that has established a state-based exchange, as well as those in Nevada who are sick will buy the coverage, but those who are well but really can't afford it will not buy the coverage. So you have a destabilizing effect in both states. A state that doesn't have an exchange from essentially the flooding, or excuse me, the death spiral of people who have to have insurance purchasing it and the healthy people opting out until they need it, versus in a state like ours, just people moving to a state that has an exchange so that they can get the subsidies. So what keeps me up at night? The big issue, Supreme Court case, will it unwind Obamacare? And again, this matters to me at the most fundamental levels of my being. And this is something, Obamacare or whatever, again, I fought more for a Medicare for All solution. But that's what's defined my career for the last 25 years. And so it troubles me greatly to do away with guaranteed issue for our sickest, most vulnerable people. And I'm very concerned about the fact that those who have coverage are finding their plans' deductibles difficult or impossible to afford. And these trends towards greater cost sharing, combined again with little or no growth in median family income, it's just this notion of increasing that burden on those who are in many ways least able to afford it. The impact on specialty drugs, very big concern. The increasing trend to move towards what's called co-insurance on these benefits. I'll talk a little bit more about that. But co-insurance essentially saying that rather than you paying a copay of $25 for your brand name drug, we will charge you 30% of whatever the cost of that drug is. And you have to remember that the drug industry was left out of any reforms. They specifically were able to argue successfully with Obama, which I hold great fall, that they should be essentially, if they supported Obamacare politically, that they would be left out of any price constraints. So here they are, and now able to say, hey, consumer, you have to pay 30% of whatever the cost of that drug is, and there are no constraints on how high that cost can go. Huge, huge issue. And then the impact of the cost sharing impacting the provider system, the hospital and physician groups. So, we have 1.4 Californians, actually we're probably gonna hit 1.5 Californians, I should have updated that, in the exchange plan by April 15th. And when we were projecting back in 2013, that's approximately twice that projection. So 88%, however, of new enrollees are eligible for subsidies. That's huge. The subsidies go from 250% of federal poverty level to 400% of federal poverty level, which is around $85,000, $90,000. So again, you're capturing a huge swath of people within that. Obviously, 88% qualifying for some subsidies. And it really tells you that the affordability issue is very paramount, that so many people in the population qualify to get subsidies to purchase health coverage. But one of the big issues in the exchange last year was enrollment of minorities. And so the original concerns were about enrollment of Latinos. There was a special outreach to Latinos, and they were successful this year in enlisting more Latinos into coverage. Young people, very important. All of you are contributing. In fact, the ratio may be about right for you to afford my health care costs, and I appreciate that. Because young people, of course, tend to be healthy, and they pay into the system and generally do not extract much from it. And so those of us who are more on the receiving end of the health care benefits, thank you for doing that. And we have to make sure that you keep on doing that. So young adults did in fact purchase coverage, many of them because they were now able to get on their parents' policy until age 26. So, but keeping the young cohort in that risk mix pool is very important. And then also they got more Asians and African Americans than projected. Federal Medicaid expansion in California, there are now 11.2 and rising people who are in the Medicaid program in California, and Medicaid and CHIP. So those numbers are combined, so it's a little lower. And they are, if you saw the headline back when some of these numbers were published, what they talked about is that roughly now a third of all Californians are eligible for Medicaid or on Medicaid. Think of the implications of that demographically. What does that mean? That means that all of those people are below qualifying to purchase coverage to be eligible for subsidies. They are in fact so poor that they are not going to register into private coverage at all. They are all going to be on public coverage. That is a third of the population of California. Huge, huge, in fact, implication. And but it's resulted in a 25% reduction of the uninsured rate overall between expansion and the exchange, which is hugely significant. I remember when I moved to California from Colorado 13 years ago, population of Colorado was 4 million. And I remembered reading a statistic that the population of uninsured in Los Angeles County at that time in 2002 was 4 million. So that the entire population of Colorado was just represented by the uninsured in LA County alone. It's pretty staggering. So getting people into coverage is of course a big, big issue. I'm going to skip that slide. Although the bottom point is important because it's one of the issues that at CoPEL Solutions we talk about we deal with, which is this issue of churn. That if you are on Medicaid and you make a little too much money, you no longer qualify, you go into a private coverage, so you're potentially subsidy eligible, but then the next couple months, let's take if you're a landscaper and you're in a seasonal business, your income will go up and down seasonally, and the margins will mean that you no longer qualify for Medicaid, or that you're back in Medicaid on a seasonal basis. Those of us who fundamentally believe in protecting the safety net from the ramifications of a really bad system fundamentally believe in what are called bridge plans. And those bridge plans essentially say that regardless of whether you're in Medicaid or in the exchange, particularly at that lower swath, that you will have the same delivery system, the same providers, regardless of whether you're qualifying for this program or that program. It's called all-payer models. That's what we believe in at COPE, and we believe in it because it best protects the individual from these radical changes in delivery system, having to take 2 buses to go to their doctor while taking their kid to another doctor. We just fundamentally believe that that's important. And a lot of our work and a lot of your work, those of you who are both at COPE but who are working in healthcare, will be around how do we figure that out? How do we make the finances work? How do we make the delivery system? A lot of the DSRIP waiver issues are about creating those kinds of coordinated delivery systems so that this issue of churning, it does not have such a big impact. The work we're doing in Texas, very much around the health plan in Texas, trying to figure out how do we create a system and a mechanism where the delivery system is always the same, quality measures the same, everything happens the same, but the check that comes from a different source to the health plan is the only variable. And again, a very important concept for us. I'm not going to spend too much time on that because I need to. One of the big trends, statewide plans won out. The smaller plans have, in fact, really kind of fallen to the wayside. They may be offered, but people aren't picking them. It has huge implications because it just means that, first of all, brand name matters. And your notion of competition was about bringing many, many players into the marketplace to compete. If you have fewer plans, obviously they have less competition, especially if they're big. And in some areas of the state, you only have one health plan choice. So that has been a huge impact. Narrow networks, I'm going to get to Tammy's point just as she left. I'll embarrass her later. But so, the reason you have to create narrow networks is because the exchange benefit products are fixed. They always talk about healthcare being a 3-legged stool. You have your benefit side, you have your whether you can choose people to go in or out, and then you have your network side. That's the 3-legged stool. And so if you have your exchange, the benefits are fixed and the costs are relatively capped in terms of deductibles, and the health plans have to take all comers, there's only one variable left, and that's narrow networks. So that's why you've heard so much about narrow networks coming out. And the premise is that they exclude the most expensive providers, and then they negotiate with those that remain. Last year, the exchange plans were very aggressive on rates, and Blue Shield is an example, essentially cut their rates on the commercial product, which has tended to cross-subsidize the Medicaid, and that's what, Tammy, I'm coming back to it. So what you had is that Medicaid pays very low rates, Medicare pays a little better, your commercial payments have tended to cross-subsidize. a lot of the providers' finances. Well, what the health plans have basically said and been saying for a while is, hey, we want to get out of that business. We're not in the charitable business. We're accountable to shareholders. Not our job to figure out the public financing system. We're getting out of this. This has given them the ability to really put rubber to the road on that concern. And so you saw Blue Shield last year, and that was one of the ones you may have read about, going out to market and saying, if you want to be in our network, then you have to accept 30% less than we were paying you last year. Well, that's pretty, if you're a primary care provider, that's significant. I mean, it is significant for hospitals. It was very significant. And many of the providers, particularly the hospitals, opted out of covered California networks in that first year because they said, whoa, you know, they wanted to lock arms and say, hell no, we won't go. And that was the strategy, even though they won't tell you that because that would be price fixing and collusion. But what happened, of course, is you got somebody break. You know, somebody broke and said, okay, we'll be in. So they were able to put together networks last year that were very, very minimal networks. Really a problem, and again, something that invited regulatory action. So, how Americans view healthcare costs. The woman wants the diamond, this is what I want, and the man basically says, you know, I'm only going to pay for the small little ring. That is a little sexist. Yeah, but sorry about that. It looked good at the time. So these consumer impacts, what you're going to see, the reason that these are significant is because they first of all affect you. They impact providers, and they lead to regulatory action that essentially changes some of the dynamics that are in place for better or for worse. So people are starting to realize that a lot of their doctors may not be available, and they're getting billed by out-of-network specialists. So their policies, some of these policies basically say you have no out-of-network coverage except for emergency care, which in California is required. If it's outside of emergency care, you have zero coverage for that. And that specialist can bill you anything they want. And, you know, that's the balance billing. And you have zero coverage, or there's a minimal payment for it. And these high deductible plans may account for 60 to 80% of the products sold nationally, and they account for approximately 40% of the products in California. And that's a $6,000 deductible on a bronze plan. Yes?
So this is where that distinction comes in, where people have access to healthcare coverage, but they don't necessarily have access to care.
You've summed it up beautifully. That is the consumer issue. It's sort of that the mantra of Obamacare may turn out to be crappy coverage for all.
Right.
You know, which frankly is pretty sad. It's a sad thing, is that you have coverage but you can't afford it. And you know, my sister has a $10,000 deductible. Now, they can't afford that, but if that $10,000 deductible, because the bronze plan is the most affordable, if you're not getting subsidies, silver plan is where you get subsidies. If you're not in that and you don't have a lot of money, that's a pretty difficult thing. And so people are really surprised by the magnitude of this cost sharing, and these specialty drugs are increasingly coming under controversial discussion. So this is just to give you a quick sense of that. The average family makes around $50,000, so it's that third category. A quick look at what those copays are. You know, a high deductible, $1,500 medical deductible, and then all of those copays, 20% of the plan's negotiated rate for high-cost services, hospital care. So you're paying 20% of the hospital bill. So that's, again, really quite significant. You're not just paying your deductible, because your deductible is listed separately. Well, I'm sorry, no, that is, they aren't paying a deductible, but they are paying 20% of the hospital bill, which is going to be very significant, you know, hospital charges. So these are really, really major issues. And then talking about the physician impacts, that one is not bad. So, you know, again, the doctors feel like they're essentially being asked to provide their coverage for free, and they always feel that way. So, it may be increasingly true. Again, losing the primary care bump, as well as the rate negotiations that the plans have been doing. So the doctors really have been pretty unhappy, and that's why you see a trend for them wanting to become employed. It's like, well, you could take the business side of this. I just want to go in, deliver care, and go home and get a check. And so you are seeing that's one of the trends that increasingly is coming up. But the docs that are staying independent have a lot of these issues. So the narrow network squeezed them out because they wouldn't negotiate. There are a lot of contractual issues with the plans. And the provider directories were a mess from Covered California, just a mess. And that's an instance where, from a regulatory perspective, I would not have allowed them to go out with that kind of misleading information. I would have stopped them from selling their product, and that's what you can do as a regulator. But if you're Covered California, you're trying to run a marketplace, you're not going to not allow them to sell the product, so you just tell people, we'll fix the provider directory, but they really haven't yet fixed it. It remains a big problem. And then continuity of care. If you don't know whether your doctor's in or out, or whether they're in for your product but not the silver product, it's very hard to know where you are in terms of that provider, and it's hard for the provider to follow your care. And then the bad debt issue for providers, big deal. And patient churn between exchange and Medi-Cal, the impact on utilization, another major issue that is influencing. When you have a $10,000 deductible, you're going to be pretty careful about using your coverage. It impacts utilization, reduce cost trends, and or reduce the trend lines significantly, but it's due to good and bad lowers in utilization. I mean, if you have a $10,000 deductible and you're having angina attacks, you may think twice before going to the emergency room, because you know that you've got a bill to pay. And I'm not going to spend too much time on some of that, so I can move a little. And again, the docs feel like, you know, again, Obamacare is trying to keep its cost down, so Dr. Chips will perform the colonoscopy. And the concern is that, you know, they talk about pushing care to the lowest level of care, but are these people really that well qualified to do that care? That's what the doctors feel. And then the delegated model in California has been significantly impacted by the exchange. So in the exchange, in California, managed care in California has always differed from other states in that it has been firmly centered on physician organizations versus solo docs. And these physician organizations in independent practice associations have taken risk, and they've taken capitation, so that they would, let's say, the health plan would get the premium of $1. They would take 15 cents of it for their administrative costs and then push down 85 cents, let's say, down to a physician organization that would actually manage the care. And California has the most robust system of delegated model in the country. I wrote an article on that issue recently because the impacts are very profound. There are 200 plus capitated medical groups and IPAs in California, and they take care of approximately 13 to 14 million people. So this is a big, big deal. And these delegated groups, there are very few of them participating in the exchange. And the reasons are, first of all, the HMO model is the model that supports a capitation approach because it uses capitation as opposed to fee-for-service payments. And so in the exchange, you have mostly PPO products that rely more on discounted fee-for-service payments versus paying capitation in advance for taking care of all of the medical costs of that patient for the month. The medical groups cannot administer high deductibles. They have not figured out how to essentially track deductibles and allow patients to know where they are in terms of those deductibles. They can capture and report encounter data. Again, a very huge deal because risk adjustment relies on fee-for-service encounter data. And so if they don't have that data, they can't report to the health plans for risk adjustment purposes. Yeah?
Is that an admin thing? Do they just not provide or have admin staff really in those groups to be able to do that? Is that just not been their focus, or what accounts for some of that inability to do those things?
It's really two-pronged. One is that if you're under capitation, you don't need to count individual visits because you're not getting paid on that basis. So you track generally what you get paid for. So when you, in a fee-for-service model, every single time a patient comes in, you click and you get paid for that visit. In a capitated model, you're trying to keep them more out of there, so you're not, your incentive first of all is to keep them out, but when they come in, you're under a global capitation amount anyway, so that it doesn't matter to track them. And the delegated groups have failed to develop the technology to track encounter visits, an enormous mistake, and I told them so way back that they had to get on it, and we worked on some solutions, but they just weren't really interested in getting the technology at that point to do that. So it's a huge, huge deal that's going to lead to
They
their
hadn't
erosion.
operated that way in so long, and they
Yes,
just didn't.
they just, yes, yeah.
It seems something as simple as, okay, I know not EHRs are simple, but just having a basic EHR system to track and record and take notes.
I know. That's what I said to them. Yeah. I mean, that would be a long story.
Okay.
You can read that article again, you poor thing. She was so nice and read my article to QA it, and I kept saying, "Are you asleep? Are you asleep?" So these are, and DOFR's, DOFR is a division of financial responsibility. Again, a very important term for you to know in this new environment of value-based purchasing and risk sharing that is a national trend, even as it's declining in California. A DOFR says, I will pay for this, and you will pay for this between the health plan and the provider. So let's say in vaccinations, the health plan will pay the cost of the vaccination, the health plan will pay the cost of administering it, and the doctor will assume the responsibility for the actual office visit in which the vaccination is administered. That would be the division of financial responsibility. But if you have a $10,000 deductible or a $1,500 deductible, it's very hard to track where you are in terms of your responsibility. If I'm responsible for the patient visit, but the patient's actually paying for that visit because they've got this cost sharing, how does that affect the dollar that I'm gonna get from the health plan? And the health plans have basically said, you know what, this is really too complicated. PPO products, easy, I just pay a discounted fee for service. So these are big, big trends, and the term DOFR, Division of Financial Responsibility, something you'll just wanna make sure you have an ear for. And then also the medical groups basically say, hey, we used capitation to build up all of this care infrastructure that now you want us to flip over and benefit your bottom line by using it in a fee-for-service environment. And, you know, again, hell no, we won't go, we don't want to do that. We'd rather, I don't know what their strategy is, believe me, I've asked, but they don't want to undermine capitation and delegation, and many of them are basically just not interested in taking PPOs. Healthcare Partners is an example of that. Healthcare Partners said, we're taking HMO products, and if you want to work with us and get the access to our systems that we built up through capitation dollars, then you have to come to us. And they have the clout to do it, but most will not have that kind of clout. Card-carrying patients are coming to the hospitals. They're coming increasingly, we think, to the ERs. And but the high-cost sharing, bad debt, charity care, safety net hospitals are at risk, and increasingly are really relying on the provider fee in California to make their bottom line. Lots of instability in the market. Daughters of Charity issues, the sale, and the projection is going to be that there's just a lot of hospitals that need to close. Even Dwayne Donner at the California Hospital Association basically says, which I think is amazingly brave, that a number of his members, his hospital members, must close. That they're not going to be able to make it. Huge trend for you in the coming 10 years to see who are those winners and losers. Most of them are going to be safety net hospitals. And there's those disproportionate share hospitals are scheduled to lose DISH dollars because they're presumably getting more insurance, card-carrying insurance dollars. But if they're carrying only a reduced payment, a Medicaid payment, you wonder whether they really are replacing those lost dollars. I'm going to skip a few slides because I don't want you guys having to spend the night. Yeah, let me move a little bit. And again, just the headline there, ridiculously narrow networks won't last. You'll see an increasing trend towards having to expand those networks. If that was the price control, then that's gone. Remember, you had your three-legged stool, the cost of the premium, whether you have to take the benefit design, was it a rich benefit design? Do you have to take everybody? Then you have to be able to exclude providers to affect affordability. So if the narrow networks don't last, then in fact you've lost that price depression capability. All right, I'm going to move quickly. This physician practice is changing, and we're seeing that increasingly they are part of a patient care team. And this is a lot of the work we're doing in the delivery system reform incentive programs, both in New York and in Texas, is that we are trying to move doctors from being solos to being part of teams and care teams. That's a huge trend, and one that I think is going to stick. Prevention and wellness, those are covered in the Affordable Care Act for preventive screenings, and so an additional 76 million people now are receiving preventive care, and that took effect right away as part of the strategy of Obama and Kathleen Sebelius to front load some benefits so that people would start seeing benefits right away and not wait for 2014 when the guaranteed issue provisions hit. So the preventive benefits have been in place since 2010. 76 million people have been affected by that. Better access to care on evening and weekends, again, part of that notion of prevention and just better access to care. Trends on the electronic health record, not the paper files, thank God. Oh my gosh. If you ever have had a sick kid in the old environment and you're printing up, you're asking them to photocopy reams of patient records and hand carrying them to the new specialist, it's absolutely ridiculous. So I've worked a lot on electronic health records, and I'm glad to see that they are continuing to advance. And then, this idea that patients should be able to be part of their care team and access their records remotely from wherever they are using mobile technology, virtual visits, and telemedicine. The providers have formed this idea that they want to cut, particularly the hospital, they want to cut insurance industry out of the business entirely. They want to move the business to where health plans are just what you might call ASOs, administrative service organizations only, like they are with a self-insured plan where the employer is taking the risk and the health plan is taking no risk. They're just figuring out how to help provide the services. And you have these large regional systems, a good example, Sutter, Memorial Care and, Sutter Health Plan, sorry, forming a health plan and trying, first of all, to knock the insurer completely out of the business of where they grow their own membership. And we'll see how that goes for them. But then also the notion of bringing the payments directly to the providers by making them responsible for more of the healthcare dollar, like Memorial Care is doing. Also, an interesting trend, and one that I would suggest you to follow, is Optum, United Healthcare's Optum. Optum really has a model about enabling, empowering providers to take risks, and there are a lot of businesses in that line now trying to help providers do that. But Optum has a suite of services that I think will help it occupy more of a sweet spot. They've got a lot of the information technology and a lot of the capabilities to really do that. So I would follow them a little bit, just as you're looking at trends in terms of doing this actuarial modeling, risk management. And then you have the Vivity partnership. I'm sure you all heard about that, where 7 hospitals just right in this area are now partnering with Anthem to figure out how to create their own network to compete with Kaiser, essentially. It's trying to create a Kaiser-like model.
You think that's going to be successful, Cindy?
No. I think, the difficulty is you take a Cedars-Sinai and you somehow put them in a risk-sharing arrangement with a much lower cost system, and Memorial Care, I'll just postulate, might be a lower cost system. And that question of how they balance each other out is hard. You don't have an underlying social agreement such as Kaiser Health Plan has with its medical group, Kaiser Permanente Medical Group. So without some of that value in there, it's hard to see how it's sustainable over time. And remember, it's only one product. So they're competing still on all their other lines of business and products, except for one slice of their business. And so it's hard to see how it's sustainable. But again, something really interesting to watch. You're seeing in that cohort of hospitals, we got to get together and figure out how to compete with Kaiser, because we're getting creamed. Kaiser is obviously very, very significant. I think they're about 45% of the membership in California. And I don't quote me on that statistic, but I don't think I'm too far off on that. So Kaiser is the big gorilla. The strategies around trying to compete with Kaiser are something you should try to understand, because again, they're going to drive a lot of dynamics on the non-Kaiser players. And the impacts on the hospitals, this is something very significant to understand, that the hospitals' bottom line, their CFOs, really are struggling how to figure out how to become accountable care organizations. How do you switch from getting paid every single time somebody comes in to the hospital, and where you have a high fixed cost structure? Remember, in California, one of the things that's happened while you guys were in grade school is that Jackie Spear led an effort to get seismic retrofitting done at all the hospitals. Well-intended, very well-intended, and put mandates on the hospitals to upgrade, retrofit, or build new hospitals. So you have a lot of new hospitals in California, and they have a very high fixed cost structure that now you're saying, all right, we're going to move the care out of the hospital into the community. We're going to reduce the inpatient visit, but hospital, you still carry, and CFO I talked to said their cost, their fixed cost structure is about 85 to 90% of 90 cents on every dollar. So for every dollar they receive on an inpatient visit, 85 to 90 cents of that is not variable, that it cannot be reduced, it's in place. So that means they're only tinkering with 10 cents, 10 to 15 cents of every one of those dollars to be able to say, well, let's move that care out of the hospital into the community, and somehow the risk payment we get is going to compensate for that loss of that inpatient dollar. That is an equation that you must understand in this business now. You must understand and talk the language of that CFO to have any credibility. Because, and this is one of my gripes about our industry right now, you have a lot of consultants going out there and just saying, hey, this is the new trend, we're going to move care outside of your hospital, and you're just going to take risk, and so you'll get this new dollar, or somehow you'll get paid at the back end for having lost the inpatient day, built out, assume the cost of building care in the community, because hospitals don't own those things. They go buy those or rent those for dollars. And somehow at the back end of that, you will get a payment that somehow will either make you whole or not. And it's one of the things that I've wrestled with a lot, is how do you make that make sense? And I still can't make it make sense from a policy standpoint or from a practical standpoint, because I'm very practical. Yes?
So what's that back end? Where's that money coming from? So if you're doing this, if you're going out in the community, you're providing that care, where's then that money coming back? Is that from the government directly?
Well, so let's always start with inpatient. For an inpatient visit under a fee-for-service environment, the health plan will convolutedly pay you $1 for that. So now you enter into a risk arrangement with the health plan, and the other thing that's really important to remember is on the inpatient side, every health plan, every payer is paying you for that visit, that fee-for-service visit. When you move over to risk, then you may have an arrangement with some of your payers where instead of paying you that fixed fee-for-service dollars, they're paying you on some kind of a risk basis. So risk can be either episode payment, meaning that we will pay you for a tonsillectomy from the time that that person starts receiving their care all the way through recovery, whatever that is. I'm not necessarily the right, or a hip replacement. So we'll pay you a bundle payment for that. Another way to get paid would be through a shared savings, meaning that if you reduce the cost of that care, of that hip replacement, we'll help split the savings with you. And so meaning you're still getting an inpatient dollar, you're getting more of a fee for service, but we'll also, if you save us some money, we'll split it with you. It's still a risk-based payment. And then capitation, where we'll pay you a certain amount of money for all of the care for that patient. And and we're not going to pay you any fee-for-service dollars, you just get one global payment for that patient. Or what you're seeing a lot of the programs do, and again in the Medicare, is we'll pay you a bonus. That's where a lot of risk right now is starting out, is we'll still pay you that fee-for-service dollar, but we'll reduce it likely, but we'll pay you a bonus at the end if you make money, if you save money for us. So you're seeing a lot of different risk arrangements, but all I'm saying there is that you have to be challenging the underlying premise. The real conundrum, how do you move to an incentive-based payment care model when the majority of contracts remain fee-for-service, and when your entire cost structure is built on fee-for-service model? It's just a very, very difficult thing. I'm not going to spend too much time on this, but essentially you are seeing and you're learning about a lot of the clinical redesign. These are hard things to do. In California, we've done a great job, but it's taken many years. Many of the delegated providers have been in the business 30 years, and they have figured out how do you create a care system that allows you to do better financially, but at the same time also receive capitation and take better care of the patient in the process. And I just wanted to highlight this because there is a lot of discussion about population health management and about case management, and about focusing on a very narrow part of a very narrow segment like the frail and ill. And it's very important to understand, and you've seen this chart, I'm sure, or something like this chart, that really talks about where the spend is. So you have 85% of people in Medicare who only spend 25% of the dollar. And 15% of the beneficiaries in Medicare spend 75% of the dollar. And then look at the very, very top 5% approximately. 5% have a huge, huge spend. So when we talk about, when you hear a glib term like population health management, what you really want to know is who's the population. If we're saying we're just going to keep people who are mostly weller, that's great. That's a wonderful thing to do. But you aren't going to be able to impact a huge amount of cost in that. If you're talking about, let's focus in on people who have at least one chronic illness and keep them weller, then you're going to impact some of that middle swath of cost. But when you're talking about how do we impact that cost with people with multiple comorbidities, I just visited my mother and visited the doctor with her. I have to tell you, her comorbidities fill an entire page. She has like 60 comorbidities, not 6. I remember like looking at it and going, wait, I thought you were only allowed to have 6 comorbidities. She's got things that, and she is not unique. So it is the real issue, the fundamental spend is in that 15%. And so what you'll see is Caramore has a solution that we think is a good solution that we at Cope Health Solutions tend to think we like to push out. It relies on chronic disease support, prevention, risk prevention, social support, behavioral supports, and end-of-life care in the frail elderly. And then talks about the relationships between the PCP, the extensivist, the case manager, and the clinical care center or the hospital. And it brings into play all of these kinds of systems, the predictive modeling, so that you have the analytics, the integrated IT infrastructure, the medical record, the longitudinal patient record, the evidence-based practices, and then this point of care decision support that makes sure that evidence-based medicine is brought to the point of care. This slide is going to be something that you'll end up spending a lot of time with your practicing of your career in. How do you help make these kinds of things happen? How are you going to impact that 15% of cost through the development of delivery systems that support and are supported by these various factors? Health jobs. Providers are going to remain badly needed, obviously. We know that. That's what our program, the Clinical Care Extender Program, is all about. And the health plan administrators, CFOs, care coordinators are going to continue to remain important. And hospital administrations are going to increasingly want clinical skills represented. So that's just something that I've heard a number of times from folks, is that they really want people in the C-suite who have some clinical background. Of course, we've saved a place for lawyers, so I put that in. But it's nice when they actually know how to do things, which isn't that often. So, and then quality care and strategic consultants, I had to put that in for Cope Health Solutions, are going to remain important. So that's a bit of where the jobs are. I didn't just make this up, although it looks like it. So, if laughter is the best medicine, why won't my insurance pay for marijuana? And so, again, we're all going to maybe need some marijuana. Conclusion. So, this ruling is unquestionably historic, but the cost of health care is the challenge, and it's the challenge that really will rest on you to be part of solving and to contribute your best endeavors to. It's a wonderful body of work to have in front of you. I mean, really an incredible body of work to figure out how do we make the system less unfair, less expensive, more higher quality, less error prone, and how do we do that in the face of all of these forces still coming in and all the protectionism, and how do you work through that? And the thing that I would say is just that you have to understand the dynamics of the delivery system. I spent a lot of time reading, because it's really important to understand, to just not hear about Vivity and go, wow, that's interesting, but to know that Vivity represents a counteroffensive to Kaiser, to understand who are the hospitals involved, how are they aligned on the chessboard in terms of their own dynamics, and just keep tearing things apart and remain curious, and also don't be afraid to ask questions, and don't be afraid to just really challenge. You don't have to accept everything or anything. And I would say one of the things that has been my success in my career is the fact that I absolutely challenge everything that I have come up against in terms of saying, you know, why does it have to be this way? Why do things have to be this way? Why do things have to be more expensive? Why do they not let little babies receive coverage just because they're sick? And at the end of the day, even if the Supreme Court strikes down the subsidies for non-state-based exchanges, they end up, and the Republicans and the Congress will end up having to figure out again, how do we take care of this 9.6 million people who are currently receiving their health coverage through those state-based or the federally facilitated exchanges. And I will tell you that we will be right back at where we started, which is, how do you guarantee issue without making everybody buy it? How do you make everybody buy it without making it affordable? How do you make it affordable without using tax money? How do you get the tax proceeds to fund it without taxing the things we don't like? So at the end of the day, I will tell you that no matter what happens, that fundamental conundrum continues, which is that you have, if you're going to use a private market system to solve the issue of how do we guarantee coverage to people who have pre-existing conditions, then you bring a lot of dynamics into play to resolve that. So I am glad to answer questions, and thank you for listening. I appreciate it. I know it's long.